So this webinar is going streaming right now, and we
Okay.
can start the webinar.
All right. Thank you so much. Thank you. Thank you, everyone, for being patient with me through all this IT challenge. All right. Good morning, good afternoon, good evening, everyone. I'm delightful to welcome you all who are calling in from different part of the world. Today we have our distinguished guests from London and also Indonesia and New Zealand coming in. I'm Dina. I am wearing so many hats, but today as the non-executive chairwoman of FMCH Indonesia, Foundation for Mother and Child Health in Indonesia, I will be moderating this webinar. This is a very special event for us at the Foundations of Mother and Child Health in Indonesia. We have been focusing our works on maternal mental health since 4 years ago, but only now we are able to do more actions on the ground, translating our visions and missions into real actions. And together with Ibu Foundation and the support of Global Maternal Mental Health Alliance, we have established Indonesia's Alliance for Maternal Mental Health. And we are inviting all of Indonesians who are interested and have a program or share similar passions to join us at the Alliance. Today's webinar is held in collaborations with the Maternal Mental Health Alliance members in Indonesia. We will be discussing global trends and issues on maternal mental health. Dr. Alain Gregor, who is a perinatal psychiatrist. I'm sorry, my pronunciation is bad. And also visiting professor at London School of Economics. He's also a chair of Global Alliance for Maternal Mental Health and the president of UK Maternal Mental Health Alliance. He will be sharing with us the global trends and issues on maternal mental health. And then we will be deep diving, zooming in the context of rural locations in Indonesia, where our consultant Herce Putra Purnama will be sharing the result of micro-study on maternal mental health in Sumba and Timor Islands of Indonesia. And we also have 3 distinguished guests who will provide comments and feedback on Dr. Alain and Herce presentations. We have Fandi, the director of Ibu Foundations, and Rinda Amalia, the founder of Teman Ibu Foundations, and our beloved Barbara, the founder of FMCH. For all of you who joining via Zoom, if you have any comments or questions, please type in on the chat. We will try to respond to your questions after the presentations and feedback from the distinguished guests. And who are, if you're joining via YouTube channel, you can also provide comments on the YouTube. Feel free also to introduce yourself on the chat room. All right, Dr. Alain, please share with us the global trends and issues on maternal mental health. You have 15 minutes to share with us. And please allow me to remind you if the time is about to end. But now the time is yours. Thank you. Hand over to you. I'm sorry, Dr. Alain, you're still on mute. Can you please unmute?
Oh my goodness. Thank you very much. Thank you very much indeed for that reminder. And thank you very much for this invitation. I am very honored to be here. And it is also a great pleasure to be with you and to hear about the fantastic work that you are all doing on this really important issue, not just for us who are here today, who are interested in this topic, but actually for everybody in the population. Because we may not all be mothers and interested in our own well-being, but we have all been babies, and we are all on this call adults who have developed from babies And the science is now telling us that period in our lives, when we are fetuses in the mother's womb and babies in our very earliest months and years, is very, very critically important to our development in every way in relation to all aspects of our health, of our well-being, of our future happiness, of our productivity, and therefore critically important for the future of the nation. So I do not say lightly that perinatal mental health is important as an investment for our human infrastructure. And the science and the economics behind this is showing us this very clearly. Next slide, please. So in the 15 minutes I have, if we could move to the next slide, please. In the next 15 minutes that I have to speak to you, I'm going to just give you a small taste of the huge amount of science that has been coming out both in high-income countries and in low and middle-income countries in the past 20 years or so, demonstrating very clearly the importance of this period and of maternal and parental mental health to human development. So here's one example of what the data and the science is consistently telling us, which is that if you take one mental health problem, depression, this is the most common health complication of having a baby across the world, in all regions of the world where this effect has been studied, and across all economic situations. Depression is more common than any of the physical health complications of maternity. And as you will all be very aware, most populations in the world now have access to maternity care at some level or other to protect them with their health, protect mothers' health during pregnancy and postnatally. But that focus of maternity care is almost exclusively throughout the world on physical health. And given that the most common problems are mental health problems, and they have now, we know, these significant effects, it is time for us to shift the paradigm, to shift the thinking in this and include mental health care into maternity care as well as physical health care. Next slide, please. And if we doubt the importance of mental health to the population of women of childbearing age, we only have to look at long-standing data now from WHO, showing very clearly that whether it's in high-income countries or low and middle-income countries, depression is the most disabling condition known to man in women of childbearing age. And it exceeds, for example, the disability, the life years lost through death or disability caused by AIDS. So depression really is critically important. And indeed, all the other mental health conditions that I've colored in yellow in this graph are in the top 10 most disabling conditions, causing the most premature death or illness in women of childbearing age. So mental health is critically important for women at this time and for mothers at this time, as you saw in the previous slide. So next slide, please. And this is a study done in the UK in a high-income country, but I show this because it's a study that beautifully illustrates the timing of depression in the lives of women. So this is a study that followed women from pregnancy right the way through, in fact, for 20 years. But what I'm showing you here is the first 16 years of data. And what you can see here is that a third of the women became depressed during the pregnancy, and then another sixth in the whole year after the pregnancy, and then another sixth in the next 15 years. So if we are looking for a time which is most efficient for picking up depression in women of childbearing age, it is during their pregnancy in terms of the numbers of women and when women develop depression. But not only that, this is, we know, a time when most women have access to some sort of healthcare. So we are already in contact with these women. So not only is it a very good time because this is when most women who get depressed start their depressions, but this is also a good time because we already have some infrastructure in almost all countries of the world for contact with these women. Next slide, please. And these are the effects I've been talking about on human suffering amongst mothers. I haven't mentioned dads, but we now also have data on fathers showing these sorts of effects also happen in fathers, not as commonly and not with such great effects on the individual or the offspring, but there is also this data showing that some of these effects do happen in fathers. But we not only have the parents affected, but we also have the children affected. And this is research that, again, has emerged over the last 20 years, showing very, very clearly, both in high income and in low and middle income countries, that there is a substantial, important effect of mental health of mothers during pregnancy and during the postnatal period on the development of their children and the well-being of their children. And I show you one example of this, but there are multiple studies showing a lot of different effects, all pointing in the same direction. And in this example, which I think illustrates it very well, you can see that whether it's anxiety symptoms or depression symptoms, if these are low in pregnancy and postnatally, so if there's no depression throughout the period or no anxiety, then you can see there the relatively low level of problems in the offspring. But if there is high anxiety or depression, either antenatally or postnatally, there is a raised level of difficulties in the offspring. And if it's throughout that, what we call the perinatal period, pregnancy and postnatally, then there is a much more significant effect on the development of offspring of the children. So the longer it goes on for, and the more the symptoms, the greater the effect on children. And these effects are not inevitable. So statistically, there's an increased risk, but most children, in fact, won't show an effect, but overall there is this rise in difficulties, and it is not irreversible. So not inevitable. Many children will be absolutely fine, even though there's a raised risk. Not irreversible. If we get things right, then or later, we can reverse these effects. But if we don't get these things right, you can see across this data that if we don't take action, then these effects continue for years in the children. In fact, we see effects now from studies going on into adulthood. Next slide, please. And this is just a list of the effects that we see in children documented in low and middle income countries, LMICs I've put for short. And you can see a multitude of effects, of negative effects, increased risk for children, not inevitable and not irreversible, but nevertheless very clearly demonstrated negative effects on child development of maternal depression during pregnancy and or in the postnatal period. So this does appear to be a very critical time in human development, but of course, this sounds like a negative story. In a way it is if we're not planning to take action, but if we do something about maternal mental health, if we take action, we have a fabulous potential for improving the future well-being of the population. Next slide, please. And here's just one example of one of these effects This is a meta-analysis, so multiple studies being looked at in low and middle income countries, involving in total over 14,000 mothers and babies, and showing very clearly from the statistical analysis that there is an impact on simply child growth and indeed stunting, so severe growth retardation risks are significantly increased in children whose mothers have suffered from depression during pregnancy or postnatally. And this is probably one of the biggest risk factors that we are seeing emerging from any studies of child growth and childhood stunting. Next slide, please. And I haven't got time to go into the data backing up this model, but I think it's really important in the short time I have just to illustrate that what we are seeing emerging from the research is an effect where adversity in childhood coupled with, in combination with, maternal mental health problems has the greatest impact on the development of children right the way through into their adult lives. So it is that combination of the two. So by adversity, childhood emotional adversity, the sorts of things I mean are violence in the family home, including during pregnancy, when you might think the baby is protected by being in the womb. In fact, mother's anxiety and stress around adversity in the environment is transmitted to the baby as well. So emotional adversity in the perinatal period in the environment of the child and the mother's mental health problems, when they are combined, that has an effect from one generation that seems to then pass on to the next generation and the next generation and the next generation. So we're not just talking about effects on the mother, the child, but also on the next generation when that child becomes a mother. Next slide, please. So these effects are very considerable, the research is very consistent, and now we have very clearly emerging, both within many countries, but also internationally, guidance stating very clearly that this is a priority issue for the health and well-being of populations, and that we can do something about it, that there are realistic options for taking action in not only in high-income countries, but appropriately developed interventions for low and middle-income countries as well. Next slide, please. But what we don't have is action yet. And one of the problems is that people fear that what little money there is not going to be well spent if we try and deal with this problem. In fact, the economics is very clear that if we spend money early in human lives, improving those areas that the science tells us needs improving, then we get economic benefits, and we get the greatest economic benefits by investing as early as possible. In other words, in the perinatal period. Next slide, please. And what we are seeing happening is gradually this science is translating through to policy, at least. And you can see on this map, green areas is where there is specific policy on perinatal mental health. And you can see you don't have to be a rich country to be able to develop these policies. We are seeing policy emerging in low and middle income countries as well. The yellow is where there is some mention in general policy. The green is where there is specific policy. Next slide, please. And to back up that policy, we are now seeing studies of the economics of investing in this area, or the economics of the costs if we don't invest. And again, you can see that we now have data in low and middle income as well as in high income countries that supports the economic case for investing in this way in perinatal mental health. Next slide, please. And We know, I said it before, we know that there are things that we can do that are effective and adapted to low and middle income country settings. So simple interventions delivered by even volunteers or relatively available community workers working across populations in low and middle income countries is effective for the challenge, to meet the challenge and improve the mental health of women at this time. Next slide, please. And we have multiple studies in multiple areas of the world. Next slide, please. You know, these challenges, we're very well aware of what they are, and I'm sure these apply in Indonesia as well as in many other low and middle income countries. A shortage of specialist health workers that can do this, that can do mental health work. We need to make use of locally available what's on the ground already in terms of resources, both people and settings. And that means a delivery of care by non-specialists who get a little bit of training. And this is absolutely possible and is effective. And we know, we are now starting to see that this can be rolled out on a larger scale than just small research studies. Next slide, please. And we also know, remember, it's a combination of the environment and maternal mental health. So we can intervene with maternal mental health, and we can also intervene in terms of improving the environment for mothers and young families. And a study from Vietnam has shown very clearly that reducing levels of domestic violence through national law and policy and reducing poverty has an impact on maternal depression, measured by the EPDS in this study. So that is a measure of maternal depression. Next slide, please. So sorry, I've already had this slide. I don't know why it appears twice, but there is guidance telling us what to do. Next slide, please. And we have now throughout the world, including, of course, in Indonesia, the development of alliances to advocate on behalf of mothers and babies and families for improvements in care. Next slide, please. And I finish with the words of the great Nelson Mandela, who said that if you have a vision, as we have in this world of perinatal mental health, of improving the mental health of mothers and improving the developmental outcomes for children, a great vision, but without action, it's just a dream. And we're not in the situation he describes of action without vision, which is just passing time. What we have is the potential for both. Vision with action can change the world and can change the future for the population of Indonesia. So I urge you to move forward on this area and improve the lives and invest in the future of your country. Thank you.
Thank you so much, Alain. Thank you. What a fascinating data and information you have shared with us at the global level. And yeah, I mean, it's just eye-opening, you know, to see the data and also the research that you have shared with us. And yeah, it's a crucial time of lives that the pregnancy. I mean, I've learned from your presentations that pregnancy is the most efficient time to detect depressions in women. So it's not just during the pregnancy, but because, you know, like the effect can go throughout their life. So that's the really most efficient time to detect any depressions in women. And also depressions during pregnancy will have negative effect on the children. And if we don't take actions during pregnancy to support mother's mental health, then it will have a long-term impact through the children's adulthood, even through the adulthood of the child itself. So thank you so much for that. Now let's hear what are the facts or data coming out from remote islands in Indonesia, remote locations in Indonesia. Our colleagues, our consultant Herce have done a great job collecting information from the ground. and he will be sharing with us the result of the study. It's a micro study that we did in 2 districts in Indonesia. Herce will be sharing in Bahasa, but Flori will be helping to translate it in English. So yeah, I give it the time to you now, Herce and Flori, for translations. Thank you.
Oke, baik. Terima kasih atas kesempatannya. Selamat sore, Bapak Ibu. Perkenalkan, nama saya Herce. Saya sebagai konsultan peneliti dari Yayasan Balita Sehat Indonesia yang bersama tim enumerator kemarin telah melakukan riset kesehatan mental pada ibu hamil dan juga ibu menyusui di Kabupaten Sumba Barat Daya dan Timur Tengah Selatan di Provinsi Nusa Tenggara Timur. Sebelum saya masuk kepada presentasi dari setiap slide yang sudah tersedia, saya bersama tim ingin berterima kasih kepada Yayasan Balita Sehat Indonesia bersama segenap pihak yang telah memberikan dukungan sehingga riset yang sangat penting ini bisa terjadi di wilayah kami di Nusa Tenggara Timur. Oke, kita ke slide pertama. Oke, untuk lokasi studi atau riset ini ada di 2 kabupaten di NTT, yaitu tadi di Sumba Barat Daya dan juga di Timur Tengah Selatan. Dalam melakukan riset ini, kami menggunakan 2 pendekatan. Yang pertama itu pengambilan data primer melalui survei kuesioner kepada ibu hamil dan juga ibu menyusui, juga kepada suami atau anggota keluarga lainnya. Pendekatan kedua, kami melalui interview mendalam kepada bidan dan kader posyandu untuk mengetahui layanan yang tersedia. Untuk jumlah responden sendiri itu berjumlah 366 orang yang terdiri dari kurang lebih 100 ibu hamil, 109 ibu menyusui, 99 orang suami, 30 orang tua ibu hamil atau ibu menyusui, dan 12 mertua dan juga 16 saudara dari ibu hamil dan ibu menyusui. Untuk jumlah bidan yang kami wawancara itu berjumlah 8 orang dan kader posyandu berjumlah 14 orang. Riset ini berfokus pada keluarga di daerah terpencil dengan kondisi sosioekonomi menengah ke bawah. Kebanyakan suami dari ibu hamil dan ibu menyusui berprofesi sebagai petani atau buruh migran yang merantau di daerah di luar Sumba Barat Daya atau di Timur Tengah Selatan. Sehingga cukup banyak ibu hamil atau ibu menyusui yang harus tinggal sendiri dengan anak atau orang tua. Menurut informasi yang kami peroleh dari hasil wawancara, hal ini mengakibatkan banyak ibu hamil dan ibu menyusui yang akhirnya harus mencari nafkah baik sebagai petani, pedagang, selain juga mereka harus tetap melakukan pekerjaan domestik di rumah tangganya, misalnya memasak, mencuci pakaian, dan mengurus anak. Salah satu bidan mengatakan jumlah ibu hamil yang mengalami keguguran cukup banyak, diakibatkan ibu hamil masih melakukan pekerjaan berat sebagai petani untuk memenuhi kebutuhan rumah tangga. Kemudian untuk usia responden, 50% itu adalah pasangan suami istri yang berada pada usia 25-35 tahun, dan 20% itu berada pada usia di bawah 25 tahun. Dan rata-rata dari mereka adalah pasangan dengan pernikahan usia dini. Di slide selanjutnya, ini merupakan hasil analisa SRQ. Kami menggunakan self-report questionnaire yang dikembangkan oleh WHO untuk mengukur kondisi mental ibu hamil dan ibu menyusui pada saat kami melakukan survei. Kami berasumsi semua responden ibu hamil dan ibu menyusui dalam keadaan baik-baik saja karena mereka tampak santai menjawab pertanyaan yang diajukan. Namun analisa data menunjukkan 42% ibu hamil mengalami depresi kecemasan, 17,8% mengalami gejala gangguan psikotik, dan 26,7% mengalami gejala gangguan PTSD. Untuk ibu menyusui, 39% mengalami depresi, 20% mengalami gejala gangguan psikotik, 37% mengalami gangguan PTSD. Hanya sedikit responden yang menunjukkan kondisi kesehatan mental normal berdasarkan hasil analisa SRQ. Banyak kasus terutama pada kehamilan pertama, di mana ibu hamil cenderung menyembunyikan kehamilannya, baik dari suami, keluarga, kader posyandu maupun bidan. Bahkan meskipun kehamilan sudah mencapai usia 5 bulan. Hal ini seringkali disebabkan oleh kepercayaan masyarakat yang menganggap bahwa memberitahukan atau mengumbar
Sorry,
kehamilan
Umerce,
kepada orang
agak
lain
pelan.
dapat meningkatkan
Umerce,
resiko
agak
keguguran.
pelan.
Akibatnya, banyak ibu hamil yang tidak mendapat perhatian dari posyandu dan baru melapor kepada bidan desa atau petugas kesehatan lainnya ketika sudah terjadi keadaan darurat. Kondisi lain yang turut mempengaruhi kesehatan mental ibu hamil dan menyusui berdasarkan hasil interview dengan bidan dan juga kader posyandu adalah banyaknya ibu hamil dan ibu menyusui yang hidup sendiri. Hal ini disebabkan oleh beberapa faktor, seperti suami yang merantau keluar daerah atau ibu hamil yang tidak memiliki pasangan yang bertanggung jawab. Selain itu, ada pula ibu hamil yang merasa tertekan akibat stigma sosial yang mereka terima sehingga menambah beban psikologis yang mereka hadapi. Lebih mengkhawatirkan lagi, beberapa ibu hamil dan menyusui berdasarkan hasil pengumpulan data adalah korban kekerasan, seperti yang terjadi di Kabupaten TTS. Salah satu responden ibu menyusui mengungkapkan bahwa dirinya adalah korban kekerasan seksual oleh ayah kandungnya saat berusia 14 tahun. Dan pada waktu itu ia masih bersekolah. Akibatnya ia menjadi putus sekolah meskipun pelaku mendapatkan ganjaran hukuman penjara selama 7 tahun. Namun kejadian tersebut tentu saja memberikan dampak mendalam bagi kondisi mental korbannya. Saat ini korban tersebut hanya bisa berharap untuk dapat hidup secara normal dan kembali melanjutkan pendidikan yang sempat terhenti akibat kejadian tersebut. Kami juga mencoba mencari tahu apakah selama ini responden ibu hamil atau ibu menyusui pernah mendengar atau paham tentang kondisi kesehatan mental. Hampir semua menjawab pernah mendengar dari kader posyandu atau bidan. Dan ketika ditanyakan apa yang mereka lakukan untuk menjaga kondisi mental mereka, jawaban mereka adalah dengan istirahat yang cukup atau meminta bantuan kepada orang terdekat untuk melakukan beberapa tugas rumah. Menurut mereka, kondisi emosi dan kondisi ekonomi keluarga sangat mempengaruhi kondisi mental ibu hamil dan ibu menyusui. Di slide selanjutnya kita bisa melihat dukungan dari suami dan juga keluarga. Keluarga terdekat yang diandalkan ibu hamil dan ibu menyusui adalah suami atau orang tua, termasuk mertua. 80% suami dalam riset ini mengatakan belum pernah tahu atau mendengar tentang kesehatan mental ibu hamil, ibu menyusui. Namun menariknya, ibu hamil, ibu menyusui mengatakan mereka sudah mendapatkan dukungan dari suami atau keluarga untuk menjaga kesehatan mental mereka. Bahkan hampir sebagian besar mereka mengatakan setiap hari mendapatkan dukungan dari suami atau keluarga. Dukungan yang diberikan suami atau keluarga berdasarkan data yang dikumpulkan, sebagian besar masih terbatas pada menyediakan makanan, dan hanya sebagian kecil suami atau keluarga yang membantu ibu hamil dan menyusui dalam pekerjaan rumah. Di slide berikutnya, dukungan dari kader posyandu. Di tingkat komunitas, dukungan kepada ibu hamil atau ibu menyusui dapat juga diberikan oleh kader posyandu. Data menunjukkan 67% responden ibu hamil dan ibu menyusui mengatakan ada dukungan dari kader posyandu. Dan 33% mengatakan tidak ada dukungan yang diberikan oleh kader posyandu. Namun ketika dikonfirmasi dukungan seperti apa yang diberikan oleh kader posyandu dalam menjaga kesehatan mental, hampir sebagian besar responden menjawab kader posyandu hanya memberikan nasihat untuk istirahat yang cukup, makan makanan yang bergizi, atau memberikan arahan atau rujukan ke tenaga medis profesional bila mana ada keluhan secara fisik yang dialami ibu hamil atau ibu menyusui. Berdasarkan hasil wawancara dengan kader posyandu, diketahui bahwa mereka tidak memiliki kegiatan, program, atau bahkan pernah mengikuti pelatihan yang berkaitan dengan kesehatan mental ibu hamil dan ibu menyusui. Beberapa pelatihan yang kader posyandu pernah mengikuti itu masih terbatas pada pola hidup bersih dan sehat dan penerapan 5 meja di saat layanan posyandu. Sehingga nasihat atau saran yang diberikan oleh kader posyandu kurang lebih merupakan inisiatif dari kader posyandu sendiri. Di slide berikutnya, dukungan dari bidan. Dari data tersebut kita bisa mengetahui 75% responden mengatakan ada dukungan dari bidan dan sebanyak 25% responden mengatakan tidak ada dukungan dari bidan untuk membantu menjaga kesehatan mental ibu hamil dan ibu menyusui. Dan sebagian besar responden mengatakan dukungan untuk menjaga kesehatan mental didapatkan saat layanan posyandu. Berdasarkan hasil wawancara yang dilakukan dengan bidan, ternyata pemahaman mereka tentang kesehatan mental masih terbatas. Bidan mengakui bahwa selama kuliah mereka tidak pernah mendapatkan materi yang membahas secara spesifik mengenai kesehatan mental ibu hamil dan ibu menyusui. Meskipun beberapa bidan seperti di Kabupaten Timor Tengah Selatan telah mengikuti pelatihan yang diadakan oleh Dinas Kesehatan. Pelatihan tersebut masih lebih terfokus pada kesehatan fisik ibu hamil dan menyusui, seperti kesehatan reproduksi, pemberian ASI, serta pengasuhan bayi. Bahkan belum ada program atau layanan yang secara khusus menangani kesehatan mental ibu hamil dan ibu menyusui. Dalam praktiknya, bidan hanya memberikan arahan dasar seperti beristirahat yang cukup, menghindari pekerjaan berat, dan mengonsumsi makanan bergizi. Hal ini menunjukkan bahwa meskipun kesehatan fisik ibu hamil dan menyusui mendapat perhatian, kesehatan mental mereka belum mendapat perhatian yang sebanding. Mungkin cukup itu Mbak Flori. Teman-teman semua, beberapa informasi yang bisa saya sampaikan dari hasil kita di lapangan.
Thank you. Thank you so much, Om Herce, for presenting the brief result of the micro study that we have conducted in Sumba and Timor Leste, in Timor Islands. I believe that this is the first time I think we conducted such a survey like this, micro research like this in Indonesia, where we really looking at the primary data of pregnant mothers and lactating mothers, and also trying to understand the support systems at the household level and also at the service level, at the community service facility level. So it's really is good data informations we have from the ground, and I do hope that can also lead us to our discussions now. I would like to welcome, maybe first I would like to welcome Mbak Rinda, who's, been trying to awake. She's in New Zealand, so it's 10 p.m. now. So I'll give the first chance to you, Mbak Rinda. Maybe,
Thank you.
After what Alain share with us and also the research, anything that, struck you mostly, especially because you are doing PhD, trying to looking at policy and practice around mental health, please. Yeah.
Thank you so much for the time. And yeah, it's night and I try to wake, but yeah, all the data is really good. Yeah. I would like to say the first time that mothers are particularly vulnerable to discrimination due to gender biases and stereotypes associated with motherhood. That's really striking fact that really woke me up, and then I know my future I wish become one of the researcher in maternal health because of that. And additionally, pregnancy, childbirth, and motherhood are often perceived as natural processes that require little to no medical intervention because of the stigma. And this stigma creates significant barrier for mothers seeking help, leading to delays in medical treatment that can negatively impact their health, and in some cases result in fatal consequences. And it's also mentioned by the previous speakers and give a very absolute remarkable data that support my notion. And also it's really contradict with WHO, World Health Organization, that said health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This means that mental health itself is so important like a physical health. However, the existence in the international policy is still blurry. I could not find any significant policy to support maternal mental health in this case. Mostly, all the policy only cite for maternity policy, which is for mother who is working, asking about gender equality in the workplace, pay, and then breastfeeding, only for that, but not in the maternal mental health, which is very sad for me, disparate. And in this case, states must ensure that everyone has access to the highest standard of healthcare. However, we need to understand that state cannot guarantee absolute health for their citizen because of various factors, including lifestyle and genetic. To uphold this principle, international human rights legal framework provide key regulation that state must consider when developing policies to protect maternal mental health. The first one is, of course, Universal Declaration of Human Rights, Article 25.1. It says that standard of living is equal with health and well-being for everyone. Means that this is part of standard of living. It's not something privileged or rich or lavish. It's part of standard of living. The second is protection of motherhood, because mostly there is a power gap between men and women. And Article 25 states mentioned that motherhood needs to be protected. And also in the CEDAW, Convention of Elimination of All Forms of Discrimination against Women, Article 12.1, about the gender preference protection to medical access. Because, like I said before, there is a gap power between men and women. And the Article 2 standpoint is the main reason of this lack medical health access is because of the financial access. And it's also mentioned by Hansi in this session that say that, well, financial resources is the main reason why we can't get that source. In this state, we need to say state need to provide all the necessary that we want for standard health. That means as citizens, we have a right to ask the government budgeting to get appropriate services that has been protected under the CEDAW. And under Committee on Economic, Social, and Cultural Rights, women's vulnerability comes from history, tradition, and culture, which influence women's social positions. This condition often restrict their policy voice and limit their ability to claim or assert their basic human rights, especially for their health. Yes, and in Article 12.1 say that this article highlights that health is not only a human rights issue, but also a cornerstone of sustainable development. Alien also said that that's really important that we invest in the first place, because it's part of the infestation, not a waste of money. And it's really sustainable, it's really matched with Sustainable Development Agenda Goals 3 about health and also mental health. In this case, the state's responsibility expands beyond merely establish adequate regulation, but also ensuring that medical professionals involving in maternal mental health receive a proper education and training. Additionally, they must maintain a sufficient number of healthcare providers to meet the needs of mother. Furthermore, reports submitted to international bodies should include details on how states allocated and utilize their health budget to support maternal health. And is there any gap between the policy and then the implementation? Of course it is, because access to medical care, treatment, and healthcare personnel is often cracked to the limitation in state resources, especially in remote area, because mostly women has a lot of different layers. We are vulnerable, we are marginalized, and unlucky live in the remote area, which means our voice sometimes and mostly cannot hear in the central government. In many cases, maternal mental health is deprioritized in public health policy because of doesn't enough money, and a lack of specialist mental health services and limited availability of trained professionals to provide necessary care. In this case, states has an obligation under international human rights law to allocate resources to ensure the fulfillment of maternal health rights, including mental health rights in this case. Imposing restriction on health care funding or limiting access to essential service can result in serious consequences such as increasing maternal mortality, untreated postpartum depression, and long-term negative impact on both mother and their children. To address this issue, states must prioritize maternal mental health by integrating into their national health care policies, increasing funding for specialized service, training healthcare personnel, and ensuring that all mothers, regardless of socio-economic status and the location, of course, can access the care they need. Additionally, government should enhance monitoring and reporting mechanisms to ensure transparency in healthcare resources allocation and compliance with international human rights standards. And how's Indonesia?
Yeah, that's interesting part.
Yeah.
I was going to ask you, how is in Indonesia?
How is in Indonesia? That's real, right? Well, good news and bad news.
Okay. Start
The
with
good news
one.
is Indonesia
Yeah.
has ratified all major human rights regulations, which
Yeah.
means that we have a right to ask our right to
Yeah.
government. However, the implementation of this regulation remains questionable. That is our duty, right? And one key reason is that health, particularly maternal mental health, is not currently a primary concern for the Indonesian government. To address this issue, I think it's essential to improve public literacy on the importance of maternal health rights, with a particular focus on maternal mental health. Increasing awareness and can empower community to actively engage in political processes, advocate for policy change, and demand better healthcare services. That's my opinion.
Thank you so much.
Yeah.
Thank you for sharing with us how the
Yeah.
that global policy framework that we can use to really advocate for the importance of having national but also local policy on maternal mental health. And it's so unfortunate that it wasn't clear or explicit in our current policy. What are the support for maternal mental health? Thank you so much.
You're
All
welcome.
right, so now let's hear from Fandi. Ibu Foundation has been engaging in different locations than us from FMCH. Fandi and his foundations have been working with community, with mothers as well in different locations. Fandi, can you share with us if you also observe the same pattern as what Herce and our study has revealed in our study? Is that the same pattern in other locations in Indonesia, maybe in your project locations in Java or in other locations that you're involved in? Share with us. Yeah.
Okay. Thank you, Balina, for the opportunity, and the previous presentation was insightful presentation about the data. And we have in Indonesia, we have still have a limitation data, and I want to share about specifically in West Java area, because IMMHA has already shared in East area in Indonesia, and I want to try share. And before this event, I was collecting several information for the news, for the article, and I want to share about the maternal mental health condition in West Java, and also this is also what we learn from our work in West Java and several areas in Indonesia. And firstly, let's consider the overall prevalence about the mental health issue in West Java. According to the basic health research or risk cascades 2018, about 10.5% people aged 15 years and above in West Java experiencing an emotional mental disorder. And this percentage is higher than the national average. And this is indicating a significant challenge in addressing mental health issue in West Java, even though this data is not specifically in maternal mental health, but it reflects to the potential mental health struggle among women, especially women of reproductive age, including who are pregnant of postpartum women. And when we talk about the maternal mental health, we refer to wide spectrum of how the emotional and psychological condition that may affect the women during pregnancy and after childbirth. And this condition can include prenatal anxiety, postpartum depression, and postpartum psychosis. And the symptoms can range from mild anxiety to severe depression. And in some cases, there are thoughts of self-harm or hurting the baby are also present in West Java. And unfortunately, the stigma surrounding mental health often makes it more difficult to mother to seek help or even discuss their struggles openly. And also, I want to talk about the risk of complication. During pregnancy and after childbirth, many women face increased stress, anxiety, even depression. And also, this is make it worse in pandemic era as economic difficulties, social isolation, and uncertainties the future, and this is increased the stress level. And the study found that maternal anxiety during pregnancy can increase the risk of complication, including premature birth, low birth weight, and both of which can have long-term consequences, especially for the child health. And support from family, especially husbands, plays a vital role in reducing maternal anxiety. Research shows that strong partner support can help mothers feel more prepared for childbirth and reducing anxiety as well, and reducing the likelihood of complication. However, there are still many cases, societal norms, and limited understanding of mental health make it more challenging for mothers to receive adequate emotional support. In some cases, like all support can even lead to postpartum depression, impacting the mother ability to bond with her newborn. And in West Java, actually the West Java government in Indonesia are trying to address this issue through various programs. For example, in West Java, we have kelas ibu hamil or pregnancy classes implemented in community health center. They aim to educate and empower mothers. These classes provide valuable information on pregnancy, childbirth, and newborn care, helping mothers feel more prepared and it can be less anxious. And however, challenges remain, such as limited accessibility and inconsistency implementation across regions, and not all mothers can access these classes because of logistical issue, financial, transportation, or maybe cultural barriers. And there is the interesting thing. This is about the alternative intervention, namely is endorphin massage. That endorphin massage has been explored in Banten, Indonesia.
Is that for the
Endorphin,
lactating mothers or for the pregnant mother as well?
endorphin massage just for pregnant women.
Okay.
Can you repeat what that's called, Fandi? I didn't catch what this was.
Endorphin massage.
Oh, endorphin massage. Okay.
Yeah.
Endorphin massage. This is alternative intervention have shown effectiveness in reducing anxiety among pregnant women. Even though primarily research in this issue is in region, not in West Java, but I think this method could be beneficial if we can more widely introduce and promote it in the other region, because they have evidence to counting the result, yeah. And maybe we can check the research at the Klinik Azhar Ramaja, Klinik Azhar Ramaja in Lebak, Banten. They say that endorphin massage show the significant reducing in anxiety level among pregnant women who receive endorphin massage. And there is also a study in South Tangerang. Tangerang is still in Banten, yeah, Banten province. Demonstrate that combining endorphin, oxytocin, and sedative massage that can enhance exclusive breastfeeding among postpartum mothers. And these findings highlight the potential of endorphin massage not only to alleviate anxiety, but also to support maternal health outcomes. And back to the West Java effort for this issue. The significant barrier to maternal mental health services in West Java is the limitation in mental health resources. And reports indicate that budget limitation and cuts currently have impacted the availability and quality of mental health services. As the result, monitoring and providing adequate care for mothers struggling with mental health condition can be difficult. Health workers often face heavy workloads, leading to insufficient time and attention to maternal mental health needs. Furthermore, there are limited specialized services that focusing specifically on maternal mental health. And there is still a stigma regarding when we discussing about the mental health openly, it's still considered taboo in several areas. And this is preventing mothers from seeking the help they need. And many women may feel ashamed or fear judgment if they express their struggles with anxiety or depression. This stigma is often rooted in cultural belief that mothers should be naturally happy and capable of handling their roles without difficulties. And yeah, I tried to write down maybe this is the alternative to address this issue, yeah, but it's not really specific. Yeah. It is crucial to increase public awareness in our environment, reduce stigma around mental health, and enhance collaboration between healthcare providers, local authorities, and also communities. But importantly, community-based intervention and community-based intervention also important to address this issue. Their support group and digital mental health platform could be effective in reaching more mothers. And we have to creating a supportive environment where mothers feel safe to seek help and share their experiences without judgment. This is essential for mother. And the last, even though efforts in West Java especially are being made to improve maternal mental health, but there is still a long way to go. And strengthening support system, increasing access to mental health services, and raising awareness can create a better environment for mother, their families, and also the children. That's all, maybe by Dina and everyone. Thank you.
Thank you, Fandi. Thank you so much. I think what you have shared it resonate well with our finding from Sumba and Timor, that the stigma, the thinking that, like Rinda also mentions, pregnancy and lactating, perceived as a normal process, a natural process. And therefore anything people would expect mothers to be ready, just, coping their bodies physically and mentally ready to be pregnant and do lactating, basically. While we also learn from aligned presentations that depressions during pregnancy have a negative impact toward children, not only when they are birthed, but also it may goes down the road to adulthood. And it really is. We can't just say that we have to do this and that. We need to start actions now. We need to start action, and this webinar is the this another milestones that we reach as an alliance on maternal mental health. But yeah, let's hear from Barbara, who have experience sharing the same patients with different colleagues from different regions on maternal mental health. Any suggestions, comments you have, Barbara, for us as the alliance in Indonesia? And you also familiar with Indonesia context, so anything, Barbara, please.
Well, actually, I think, hello, everybody. Hi. I work with Alain at the Global Alliance for Maternal Mental Health, but I also happen to have lived in Indonesia for 7 or 8 years and helped found FMCH. So, Selamat sore, I think it is. I haven't spoken.
Yes, you still got it. That's correct. Selamat sore. Yeah.
Very good. Okay, so very interesting reports from FMCH and the Ibu Foundation. Really, really interesting. And I think you both highlight the fact that we need to raise awareness in Indonesia, don't we? We need to raise awareness in the general population. We need to raise awareness amongst healthcare workers, community healthcare workers. And as Alain mentioned in his excellent presentation, they're starting to find ways, and actually, Fandi, you mentioned this as well. We can work on supporting mothers without having to go to hospital or something like that. We will be able to help these mothers. And I think your endorphin massage sounds amazing, absolutely amazing. So I think as you've all said, you've all pointed out things. We need to advocate for change in Indonesia, and that's informing the government, telling them why it's so important, that it affects the lives of women and their children and future generations. I was also struck by one of Alain's slides where he mentioned how, of course, one of the side effects of depression and anxiety and mental illness or mental ill health in postpartum women was malnutrition and stunted growth in the children, because of course, as Fandi also mentioned, if women have difficulty breastfeeding and if they're feeling very low in mood, then they're not going to feed their children properly, and then we do get into the malnutrition and stunting and everything. So we need to get back to the focusing on the root cause of malnutrition and stunting. It's not that there isn't enough money in Indonesian families, it's the emotional well-being of their parents, and we need to help with that. So as Rinda also pointed out, we need to advocate. We need to advocate for change, and I think you as an alliance can all come together now and work out what do you want to focus on? How do you want to do this? You know, you have to tell the government, okay, raise awareness at government levels. We have to train the healthcare workers and cadres, and we have to raise awareness in the public. What I did want to ask Herse was, he mentioned that, I made a couple of notes, he mentioned that in his report, there were midwives visiting and midwives did help, but how often do the midwives visit after childbirth? Can you answer that, Herse?
Ya, baik Ibu Barbara. Terkait dengan kunjungan bidan ini, dari data yang kita kumpulkan, itu tidak cukup signifikan, tidak terlalu
Yeah.
sering. Karena kunjungan bidan ini hanya sebatas dalam tadi, misalnya mau persiapan kelas ibu hamil, atau juga ada keluhan-keluhan yang disampaikan dari ibu hamil melalui kader posyandu ke bidan, sehingga bidan itu baru memutuskan untuk melakukan kunjungan. Jadi tidak punya jadwal yang tetap atau tidak menyeluruh ke semua ibu hamil ataupun
Okay.
ibu menyusui seperti itu, Ibu Barbara. Ya.
Okay. Okay. And would I be correct in thinking that posyandu is still once a month?
Yes, that's correct. Posyandu
Okay.
still once a month. Yeah.
Ya,
Okay.
untuk
So
posyandu itu
actually,
sesuai dengan
sorry.
jadwal itu di setiap bulan 1 kali. Namun agak disayangkan masih isu partisipasi dari ibu hamil ataupun ibu menyusui itu belum terlalu baik, dan biasanya mereka hanya akan hadir cukup banyak ketika bulan operasi timbang yang biasanya dilakukan 2 kali dalam 1 tahun. Seperti itu, Ibu Barbara.
Oh, right.
Ya.
Okay.
Dan itu karena
Okay.
sudah menggunakan
Alrighty.
misalnya aparat desa, kepala dusun yang ada di aparat pemerintah desa. Sehingga untuk tingkat partisipasi itu masih sangat bergantung dari dukungan-dukungan dari pemerintah desa. Tetapi partisipasi yang setiap bulan itu ada beberapa alasan yang kita temukan juga di lapangan. Misalnya karena jarak yang jauh, atau mereka kadang merasa ketika pergi ke posyandu itu tidak mendapatkan bantuan apa-apa, hanya melakukan penimbangan, lalu juga hal-hal yang biasanya dilakukan seperti itu. Ada semacam pandangan-pandangan seperti itu di masyarakat desa, Ibu Barbara.
Okay. That's really interesting, really interesting. So great research there. And I feel sure, because I know we've got limited time, so I'm not going to talk anymore, but I feel sure that we can all come together and discuss this further. Okay, thank you.
Thank you so much, Barbara. We still have 10 minutes though, so I will check with our participants who's joining via Zoom if they have anything they would like to ask to any of the speakers, of anything they would like to share, if they have any experience implementing, or supporting pregnant mothers or postpartum mothers in regards to mental health. Anyone want to share anything with us? Feel free to open your microphone and shout it out. No? I'll give it a bit of a time. No, silent. I take silent as a no. So, Alain, if you're still with us, do you have any questions or comments you would like to make in regards to the study that we've done, or anything that Rinda or Fandi have shared with us?
Yes, thank you. Absolutely fascinating presentations that I've been hearing, both the Indonesian data that you've managed to collect and analyze, really, really interesting. And of course, the policy context that I've been hearing about, really incredibly important, both of those. And I'm really struck by the findings that, in a way, provide us with such a challenge, but also with a wonderful opportunity. In particular, from the data that you had, where mothers were saying in huge numbers that their mental health was not good, that they were suffering with difficulties, really astounding proportions and numbers of women suffering, but very positively also saying that they were receiving support, both from families and partners, and from midwives in relation to mental health. But those partners saying, the vast majority saying they knew nothing, never heard of mental health difficulties. So they're being humane, but they're not being given by anybody the tools, the understanding with which to do what they are trying to do, and which the mothers greatly appreciate. And similarly, the midwives saying they have, I can't quite remember the details, but essentially saying they have no training and no time to do the work that they're trying to do, and that the mothers say is so important. So this, in a way, is a fantastic opportunity, because the people facing these challenges want and are trying to do their best.
Yeah.
They're not getting the support. And this is a loud message I'm hearing for government, essentially, because this is not just one or two people who need to sort themselves out. This is the people trying to do their best, but being given no help and support at a national level, with information, with policy, with training. And yes, NGOs, charities have a role to play in doing some of this, but they can't do it with no resources and with no prioritization. So the government must now, with this science, with the international policy context, and we're hearing very clearly from Rinda, international policy, WHO priorities, everybody is saying this is important. National governments now need to take action. And finally, hearing from Barbara, the only way for that to happen is governments don't know this naturally. This isn't obvious. They need to be told very loudly, this is not only important, but your population is struggling with this, your population is suffering with this, your population is trying to do something about it. And everybody will be pleased if you use the international solutions to arrive at better well-being for your population. So what would I add to that? Well, it seems to me that everything is ready for a concerted action to push government, and to do that internationally. Our experience is, do what you have started doing, bringing together people and organizations in Indonesia to speak with one voice. But the task seems so big to me that maybe you need more than 2 fantastic or 3 fantastic organizations. You need maybe 5, 10 organizations, all coming together, all saying, we will work together to make this better for our population. So I would urge you, and we will be happy to help you at the Global Alliance, to bring other organizations together before you shout at the government and say, now action. And I think this will be so powerful, and this will obviously, your data shows, change the lives of so many people who are trying so hard to help themselves.
Yeah, thank you so much, Elaine. Yes, it's really is another stepping stone that we achieved together at the Alliance with Ibu Foundations, with Teman Ibu and ourselves. And we are, yeah, I mean, the only way I can see ahead is really to bring the informations from what you have shared at the global level and also what we have shared today from the research, micro research we're doing, Fandi informations and Rinda assessment as well on the policy level, to bring that into, you know, another discussions with other peers organizations, with other, you know, colleagues who share the same visions, but also who might not aware of the current situations and challenge on maternal mental health. I believe there's many other organizations who might work on mother and child health, but not having the awareness of the, you know, the importance of maternal mental health and what are the current challenges and fact around it. Yeah, so yeah, it's a homework for us at the Alliance, I would say, but we take this on with great patience to you know, to discuss further and really make a concrete actions point, you know, to for this country, for Indonesia, for the community where we work. And I'm so glad also to hear there's already some innovations to support maternal mental health, the one that Fandi have shared. Maybe as an alliance, we can also share that together, explore that together, you know, or maybe we can also try it ourselves to do something really on the ground. For us at the FMCH, we see that there's an urgency to start helping the midwives and the posyandu cadres in our supported villages, you know, to bring the informations to them, because even during the data collection itself, it becoming like an awareness sessions for people. They never heard about mental health before. The researchers try to, you know, to simplify the word, the languages, so that they are more aware of it. And now they, because of the research, they are having more awareness of it. At least they know, oh, there is a connections between physical and mental health, and there is something about it, you know, like that they need to know, and there is something missing from the services right now. So we have the responsibilities as, you know, as a GSO who've been working in this community to also support them on this maternal mental health. So we'll see what we can do internally. Probably we will work together with Rinda and Fandi, developing something for the posyandu cadres, you know, like training, a simple training for them, so that they're also aware of the mental health during pregnancy and lactating. And yeah, we'll see what will come out with that. But I completely agree with you that we have to be more bold in actions, especially to urge our governments to pay more attention on these issues. We are arriving right on time now to end this webinar. I wish we have more time to explore more, to discuss more on actions, because, you know, we really want to capture not only the fact, but also give us inputs toward actions. What can we do next after this research? What can we do next? But you have pointed out some few actions we can take on board at the Alliance of Maternal Mental Health in Indonesia. All right. So thank you so much once again, everyone, for joining this webinars. We still have all of the information. It will be there on the YouTube channel. It stay there as a live, but also, you know, everyone can still access the information we've shared in the webinar through YouTube channels. We will also circulating the PowerPoint, the informations that have been presented to everyone joining today. And also feel free to reach out to us at FMCH Indonesia if you are interested to be part of these actions for a better maternal mental health in Indonesia. All right, thank you so much, Alain Herce, Fandi, Rinda, and Barbara for joining today. It's really been a grateful session for us and for everyone. I hope so. All right. Thank you. Enjoy the rest of your day.
Thank you. Thank you.
Thank you. See
Thank
you.
you.
Bye.
Fantastic.
Bye.
offering.
Thank
Thank
you.
you.
All right. Thank you also, Flori. Thank you untuk interpretation-nya. Makasih banyak ya, Flori, Om Herce. Thank you.